Good afternoon. Got a few people grabbing a seat, and we hope a few more people join us. I'm Dave Keeley. I'm a family physician, public health physician here in South Carolina. I've been 35 years up in York County, and I'm president of Healthcare for All South Carolina. We're very grateful to Alan Brett and Palmetto Health Richland for helping coordinate this time and place. And on behalf of Healthcare for All South Carolina, I welcome you, and I hope that you are ready to hear some very important information about healthcare reform and what's going on in our nation and here in South Carolina, and some options that we need to be looking at. To my right is Dr. Ed Weisbart, and he's our featured speaker. He speaks nationally for Physicians for a National Health Program, which many of you hopefully know is a national group of about 19,000 physicians who are of the mind that a single payer financed, publicly funded but privately delivered, improved and expanded Medicare for all model is where we should be moving in this country. And Ed is a family physician also by training. He has spent many years in the Chicago area, and then most recently he's in St. Louis and teaches with the Washington University School of Medicine. He is an advocate for common sense in healthcare. He has been in front of the Missouri legislature making the case for Medicaid expansion in the state of Missouri, which so far Missouri has not expanded Medicaid. And he is also a very adept and entertaining discussant. So Ed's going to, I'm going to turn it over to Ed, and following Ed's presentation, we will have time for questions and answers, and Dr. Brett's going to have a microphone in the audience so that we can record the dialogue. So without further ado, Dr. Weisbart.
Thanks, David. You didn't tell me I had to be entertaining. Now I'm in trouble. And you reminded me of the Missouri State Legislature, which is not a fond memory. So you can tell if an audience thinks they're going to a rock concert or a religious experience. In churches, we tend to sit in the front, and in the back, actually, and in rock concerts, we tend to sit in the front. So you're all apparently anticipating sort of a religious experience here, and I'll do my best for you. I'm really glad to be here. Delighted to talk to you folks, so many bright-eyed and cheerful faces. And we have a lot of important things to talk about, as you heard. What I'm expecting to do for the next period of time is I'll give you sort of an overview of how I think healthcare works in the United States compared to the rest of the world. And some of that you'll have seen, be familiar with, but there's going to be a number of things in there that I don't think you've thought through in the way that we'll try to present to you. Then we'll talk very briefly about the Affordable Care Act, some things that are changing, like 30 seconds on that perhaps. And we'll go more specifically into the Medicaid implications of the ACA, both for South Carolina primarily. And I'm going to call a couple of examples out of Missouri, because some of the data that I'll show you is hard to get. So I think it'll transfer pretty closely, though. And then at the end of that, we'll move into what, as you heard from David, I think makes just more sense, and that we could stop having these meetings if we simply got it right in a manner that we can learn from the rest of the world. So we'll go into that. Is that roughly, I guess it is, that's how I was introduced. Is that roughly what you were expecting while you're giving? Yeah, good. This is just sort of an image of how I got more intimately connected to this topic. In addition to what you've heard, I also volunteer with the group called the National Association of Free and Charitable Clinics. And this is the organization that supports the 1,600 or so brick and mortar free clinics around the country. In addition to doing that, they sponsor one-day massive free clinics for uninsured people in different cities around the country. And I've volunteered at, I think, 8 of them so far. The next one will be in Madison, the beginning of August. They get out-of-state licenses temporarily for docs, so anybody here who wants to go to Madison in August, come see me afterwards. And they rent out the big convention center in town and bring in volunteers like me and maybe some of you. And we see typically over 1,000 people who don't have insurance in one day. We deliver primary care, some specialty care. We get them 3 months worth of medications. We connect them with aftercare in the community. We're going to have navigators at the next one and do some on-site point-of-care testing, all that stuff for uninsured folks. This is what a line waiting to be seen looks like. This is actually about 1/3 of the line at this particular event in Houston. And I'm showing you this because it's one thing to know how many tens of millions of uninsured Americans we have. It's another thing to see 1,000 people patiently and sadly very gratefully waiting for someone to take care of them. We'll talk more about them in just a moment. Here's what some of the volunteers look like. And then this is Bobby Kapoor, an emergency room doctor who was the medical director for this event in Houston. And here's what more of the volunteers look like. This is about 2/3 of the group. I'm showing you this because we get a lot of volunteers. We often get over 1,000 volunteers for a one-day event. And I thought when I started doing this that they would be sort of like-minded to me, but it turns out they're not. It turns out that they come from every political position you can imagine. They come from every faith-based position, every lack of faith, every socioeconomic. It's a pretty diverse group of people that volunteers. And that to me is really encouraging, because to me that says that despite the apparent dichotomy in our country between the red states and the blue states, between Fox News and MSNBC, despite how polarized we see, at our heart, Americans actually, we want to help each other. We like helping each other. It's part of what we do. It's in our DNA, perhaps. It's probably what all human beings like to do, but mostly I know Americans. So we do actually we disagree about politics and strategies and tactics and stuff like that. But it's very optimistic to me to think that actually at our core, we actually tend to agree about things. So who are these folks that come to these clinics? There's a mix of the ages of people that come in. And I'm showing you this because that shape of ages versus how often they come in, that's different from this chart, which is office visits to physicians across the United States. They're very different shapes. And why would that be? Maybe many reasons, but the obvious ones to me are that we have some policies in this country. We have S-chip. It's an imperfect but pretty good solution for children. And as a result, I think, we don't see very many kids. I've stopped recruiting pediatric volunteers because we just don't get kids. And we also have another imperfect but pretty good solution in the country for seniors called, of course, Medicare. So we see very few seniors. So the policy decisions that we make have a real impact on people, So if we could step back for a moment and think, how does our healthcare system perform? Probably the single most important metric of a healthcare system compared to the world is life expectancy. And there are many things other than the healthcare system that affect that, of course. I'll show you some data about that in a moment. But life expectancy. So here we are on the left, that blue bar, and here are all these other countries where people actually live longer than us, some of whom you might have expected. There's Canada scrolling up, but many of whom you probably didn't really think would live longer than us. I'm going to show you a handful of charts sort of like this. Some will like this one, will have so many countries along the horizontal axis that you can't read that. And don't worry, we'll always be the country that looks different in color-wise, so we stand out. Some will have far less countries on them. That's not because I'm carefully selecting which data to show you. I'm showing you all the data from the sources when I'm showing you a slide of this type. It's because they come from different sources, and some have a lot of countries, and some of the studies just don't. So you've probably seen this, our life expectancy. We'll show you more about that momentarily. And you've probably seen this, that we spend double what most countries spend on health, actually what almost any other country spends per person on healthcare. But you may not have seen this, the breakdown. So it happens that our tax dollars today for healthcare are higher than the total healthcare spend in any other country. Our tax dollars today for healthcare are higher than any other country's total spend, if you include, as I think you should, the cost of providing healthcare to government employees, the tax breaks the corporations get for providing healthcare, along with the cost of administering Medicare and Medicaid. If you include all that, and this is important to me because one of the first things you'll hear people say, well, single payer, it sounds great, but we can't, have you not seen the debt, you idiot? We can't pay for that. Well, we're already more than paying for that. to show you all of this data combined in a fairly wonky way, and I apologize, this is my wonky slide. Of all my slides, it's the wonkiest. So there's what countries spend, and there's life expectancy. Actually, I guess that's birth. So that's life expectancy at birth. So a couple things about this slide. The first is that in general, as a country spends more on healthcare, in general, you live longer. In general, that's a good thing. That means that what you all spend your time doing, what I spend my time doing, actually does help people. The other thing that economists tell me that the scatter around the curve has an R squared of 0.75 or something, and that means that 75% of the variation in life expectancy among countries is explainable by what a country spends on healthcare. Not 100%, there's other stuff, but 3/4 of the variation in life expectancy is from what a country spends. So which one of these dots is the United States? Anybody want to guess which dot is the United States? No, putting you on the spot, no? Okay, so we're not on the chart, we're over here. Yeah, we're over here. So we're not performing anywhere, our system is not performing, despite having the best doctors, hospitals, nurses, pharmacists probably in the world in my mind. Despite that, our system is not performing at world standard. And if we were, for our current spend, we should be living roughly 4 years longer than we are today. Or if we wanted to just live as we are and save money, by world performance standards, we should be able to save nearly $7,000. So we're not getting what we're paying for. And this is important not just for the economics of it, but these costs impede our ability to get care as compared to the rest of the world. So if you ask folks, do they have a cost-related problem accessing care, we in the United States clearly have a higher percentage of people who identify problems accessing care due to the cost of their care than anyone else. Well, of course, that's not in small part because of how many uninsured people we have, and they, as you can see, have real problems with that. But even if you eliminate that, if you just look at the people that have insurance, it turns out that our insured Americans today have worse access to care because of the cost of care than anybody else in the world, the modern world does. So this, to me, is part of the reason why I have a very, I think, nuanced view of the Affordable Care Act. There's a lot of things, as you're going to find out, as you probably already know, that I'm not thrilled about with it, but there's some things that I am ecstatic about it. And there's like a patient bill of rights essentially built in that, no pre-ex and such. And this is really important. This is not perfect, but we're moving people from the red bar down to the white bar, or closer to the white bar. Probably won't get all the way there, but we're moving people from the red bar to the white bar, and it's hard for me to not just fall over on the fact that getting insurance means you're going to have less cost-related access problems for care. So I like that. So what happens to our life expectancy? Well, it turns out that one of the sad things that we lead the world on is from amenable causes of death. Things like diabetes, stroke, heart attacks, bacterial infections. More people die in the United States per capita from things that would have been amenable to healthcare had they had access. And I think part of the reason for that is in part this curve. It's sort of a crudely drawn curve, I guess. But if you do a quality improvement program, if you do a clinical outreach, if you do a prevention campaign, it takes a few years for those programs to really reach a population, right? It takes a few years to really impact life expectancy. But insurance companies know that they have 20 to 25% turnover in their membership every year. I was chief medical officer at a health plan for years, and I know this intimately, because your employer offers a different insurance company. Your employer offers 2 or 3 insurance companies, and you pick the other one next year. You change your job, and they offer a different insurance company. You lose your job. For whatever reason, insurance companies all know that 20 to 25% of their members are going to be different next year. They'll get new ones in, and old ones will leave. So as a result, this is the curve that they live within. That's about a 20% drop every year. So they know that someplace around year 3 or year 4, most of their patients are going to be somebody else's patients, and they're going to have somebody else's patients. So when I go there as a physician trying to talk about a quality improvement program that's going to have 5 to 10 year turnaround in value and improve the population's health, I'm just doing that Dr. Baby Talk thing, and they don't really kind of get that at all. They want a turnaround that's short, and that's the only kind of program they want to invest in, except for the ones that would attract the healthy and discourage the sick from joining them. So So our system fundamentally disconnects us from the opportunity, from the advantages of doing long-term healthcare planning. We can put some Band-Aids around it, but it's a big problem. So we're great at this, right? We have among the fastest access to elective surgery. Most people in the modern world have pretty good access to emergent surgery. You break your hip, that gets fixed, usually, most places. But elective surgery, you hurt your knee and you want to get your knee fixed and such. 93% of Americans can be seen within 4 months for elective surgery. I'm showing you this because this is the range in this study. Canada out there, if you can see it over there, is 75%. And that's meaningful to me because one of the things you think about when you think about this single-payer Canada stuff is, Canada's got what we're going to be talking about is, well, yeah, but have you seen the waiting lists? People wait forever out there. Most Americans probably have the general sense that something like 80% of Canadians wait 5 years to get, something fixed. Well, here's the data. Here's the data. The data is that 75% get in within 4 months. And can we do questions afterwards? Yeah. So most Canadians get in. Most Canadians actually do get in fairly quickly, according to the data. We actually don't go to the doctor very often. There's doctor visits per year. We don't have that many doctors compared to the rest of the world, but we lead the world at this. And some of these, of course, are terrifically wonderful, hardworking, well-intentioned, passionate, smart, brilliant people who would be necessary for any healthcare system. But we got a lot of people in this category. And notice that it kind of picked up there right around the emergence and dominance of the managed care world. So who are these folks? Well, we have roughly 500,000 practicing physicians in the United States, roughly. We have a little more than that in healthcare management. We have a lot more than that of registered nurses, and that's, I think, probably a really good thing. But we have a ton of folks in office support. These are the people that help sort of file the claims and handle billings and account receivable, that help patients navigate through their insurance system. So we have a lot of them. And actually, if you do the arithmetic of employment in the United States and hospital beds, it actually turns out that we have more full-time equivalent people in the United States working in hospital billing and account receivable than we have hospital beds. So the average hospital in the United States could take one billing and account receivable person, remote office them at the hospital bed, and still have somebody left over. That's a lot of people. And they're good folks. I'm not being critical of them. They're good folks. But that's what we need to support this system that we've chosen to do, that nobody else, no other place in the world does that. As a result, a third of what we spend on healthcare is for the administration of the healthcare, a third of it. And I retired not that long ago. I now pay my own premium through the marketplace, and I pay a $1,300 premium for my family, which means that every month when I write my check, $400 of that is going to the administration of healthcare rather than to the healthcare. So 31%. Understand that in the rest of the modern world, it's typically 2 to 10 or 12%. Medicare is on the 2 to 5% range, depending on who you read. Medicaid in Missouri, where I have a lot of data from, is 2% overhead. So that's where we are. The Affordable Care Act brings many good changes. So the unequivocal good thing in my mind is that there's millions of more people with insurance. There's patient protections with insurance regulations. Again, no pre-ex, no rescissions. We can talk about that more if you want, but I'll bet you've had that beaten into the ground in your heads. We have premium tax credits for people in a certain level of income, and we'll talk about that. And we have strengthened Medicare. Medicare's trust fund is now, I think, 16 years out, which is among the longer times it's been. That doesn't sound very long when you're thinking about a long-term plan, but actually it's always in the 10 to 20 range thing, and then there's adjustments that keep it going. So it's actually stronger because of the Affordable Care Act. And lastly, Medicaid. So Medicaid is the topic. I want to kind of dive into Medicaid for a few moments if we could. So Medicaid in South Carolina is like Medicaid in many states in that you have to be in one of these buckets that matches up with a level of income, and you probably know that. So on the left axis is federal poverty level with a percent. 100% is the federal poverty level, and then the dollar amount for a family of 4. That's what I chose just for the example. So if you're working disabled in South Carolina, you can be at that level. If you're a child and your household income is 208%, you can be there. If you're below 200%, you can have hospital coverage. So you're choosing to cover the hospital, but nothing to keep you out of the hospital. I don't really kind of get that. That seems That seems peculiar to me. If pregnancy, you're pretty good at pregnancy, you're better than Missouri is at that, and family planning. Age, blind, and disabled, you're identical actually to Missouri. And parents, you're actually dramatically better than we are in Missouri on parents. So that's Medicaid in South Carolina today. If you're not in one of those buckets, you ain't getting Medicaid in South Carolina today. So the ACA, as you know, said, well, we want everybody to have a pathway to affordable care, hence the name. And so they said, first of all, if you're between 100 and 400% of the poverty level, we'll give you a subsidy for your annual income taxes that you can apply to your premium, and you don't have to wait till the end of the year. You can get it like every month paid directly to your insurance company, and then we'll square up at the end. So there's that, with a big generous subsidy at the bottom, so your premium might just be 20 bucks that comes to you compared to a fairly minimal subsidy at the top, so it's a spectrum. And then they said people below 138% of poverty, everywhere in the country, let's kind of flatten out some of these crazy buckets, and everywhere in the country, let's make it 138% or poorer, you get Medicaid. And you may have heard 138 or 133%, and it's actually the same number. It's arcane, but the law says 133% of poverty plus disregard the first 5%. So if you hear both numbers, they're both right or both wrong, whatever way you want to think about that. And then, so this gray zone in the middle of between 100 and 138, I think, was written into the law so that if you're a wealthy or poor, you could pick. I don't know. So anyway, here's South Carolina's Medicaid program tomorrow. It's kind of a lot like South Carolina's Medicaid program today, unless you make the change, because as it's turning out, until you make this change, that I hope you all do, I hope we do too, if you're under, I find this morally egregious. The population who most needs the help is getting the least help from this whole process. So we got to fix this. So who's supposed to pay for it? Well, it turns out it's free to South Carolina for the first 3 years, 100% of the cost. And it's not based on when you join, it's based on the ACA. So from January 1st, 2014 until January 1st, 2017, 100% of the cost is paid for by the federal government through our taxes that we pay the federal government for, of course. We paid for it. And then gradually increasing so that by 2020, the state has a 10% share. So in other words, this is what you're already paying in your taxes, and you're not getting it. So we're paying the taxes. By a state choosing not to be in the program, your federal tax rate doesn't get cut. You still pay the taxes as if you were in the program, and yet, and I'm a fiscal conservative. I don't like paying for stuff I ain't getting. So that's just not right. That's just not right. So let me talk about some of the controversies that we've heard in Missouri and that I'm pretty sure you're hearing or you will be hearing here about when you're advocating for expansion. My favorite one is this one, frankly. It's this concept that, well, yeah, Medicaid, why even wanting to do that stuff? They proved in Oregon that expanding Medicaid didn't even help anybody. And you want to spend money on Medicaid? They proved it. There was a randomized controlled trial in Oregon that proved it. Have you heard this? Raise your hand if you've heard this. Yeah, it turns out they're not lying. There was a randomized controlled trial in Oregon. In 2008, Oregon decided that they had enough money to expand Medicaid a little for about 6,000 more people. And rather than just go up on the income level or something, they took the financially qualified folks and picked 6,000 randomly and gave them Medicaid. And they matched them with another 6,000 people who were financially indistinguishable on a population basis and didn't give them Medicaid. And they compared what happens when you do this. You don't get that in healthcare benefits, but they did that. So it turns out the stuff you'll be hearing is that the 6,000 with Medicaid has the same life expectancy, the same average blood sugar, the same average blood pressure as the 6,000 without Medicaid. So if you're not changing the average blood sugar or life expectancy for 6,000 people by giving them Medicaid, why in the world would you give them Medicaid? You know how much money that costs? That's crazy. That's true. That statement is true, but incredibly misleading. Incredibly misleading. So what's the rest of the story? The rest of the story is that it was 6,000 people. It wasn't 50,000 people. It sounds like 2008, but new data, like it's been 6 years. Actually, the average patient was in this study for about 18, 17 months. Also, it turns out most people in Oregon, like most people here, don't really have diabetes. So if you look at the average blood sugar for 6,000 people, 95% of them aren't diabetic. So the average blood sugar it has to be a huge study to see a change in the average blood sugar between these two populations. Or you have to do it for a really long time to change life expectancy. So So those statements are true, but they're incredibly misleading, and everything else was really positive. So for example, if you just look at those who had uncontrolled diabetes, that group fell significantly. And if you look at elevated cholesterol or blood pressure or those, so the people that were at risk for these things, that had these things, improved. And they started getting more tests, right? They got their cholesterols checked, they got pap smears, they got mammograms. And the reason I'm showing you this is because one of the arguments about, well, if we expand it, let's make sure, let's require them to go get their preventive health care stuff. Well, that doesn't, it turns out if you just remove the financial barriers, people go towards it. People do it. I don't have data for South Carolina on this next thing, so let me kind of zoom in on Missouri, but I think it's true here too. So we've had this argument a lot, that if we expanded Medicaid, we would have to cut schools. Have you heard that? If we expand Medicaid, we got to cut schools. We can't pave the roads, and you know, our roads are a lot like your roads. I'm not sure they are paving the roads. So if we expand Medicaid, we have to do that. Have you heard that? So that, you know, we just have too tight of a budget. It turns out not really to be true. It turns out not really to be true, at least in our state, and I think here, but I haven't seen this data. So it turns out in our state, if we expanded Medicaid, all those new jobs, and I think here it's 44,000 of them, they'd be paying taxes on their new jobs, and they'd be buying stuff. And here's the really big kicker. This is 3 times as big as that. Some of the things that today are on our general ledger that we pay full freight for, or we pay at the 60-40 match, would move over to the 100% or 90% match. And this is a lot of money. This is more money than the first piece. And I haven't seen that analysis for South Carolina, but I gotta believe you've got the same thing going on. So in our state, because expansion was budget favorable, when we proposed it, when our governor, we have a Democratic governor, when he proposed it, he said that there was going to be $15 million new dollars in those taxes and another $30 million that would have been offloaded for not being our responsibility and going over to the federal match. So, and because we didn't do that, we had to cut higher education and infrastructure and all kinds of other stuff. So it's kind of crazy. At the end of the day, it would have added $1 billion to our budget had we done it last year. And I'll bet you're in a similar situation where it's actually budget favorable. You don't have to view it as a trade-off between, you know, can we afford this or can we afford that? It actually can fund other things for the state. So it's a big deal. It's life and death issues. You would have thousands more women getting pap smears and mammograms, better treatment of all kinds of diseases. And at the end of the day, if you do the arithmetic on the studies, hundreds of lives would be saved. Between 200 and 500 less people dying per year needlessly. That's 1 or 2 people a day. That's 1 or 2 people today who probably died, who may not have died had you done this last year. So that's why I'm here. That's why I'm traveling. That's why I'm traveling around. That's why I'm not seeing my wife tonight. It's because there's hundreds of people. You know, it's just crazy. What does that have to do with single payer? Well, you know, aren't you the single payer spokesperson? Here's one of our founders, actually a friend of Alan's, who said this about he's a founder of PNHP, and he said this about Medicaid. He said, Medicaid, I'm just going to read it to you. Medicaid is far from perfect. Raise your hand if you disagree. If you think Medicaid's perfect, raise your hand. No, nobody? Okay. Medicaid is far from perfect. In many parts of the country, Medicaid pays so little that many patients have trouble finding a doctor who will accept it. So you know this, you know that if I see you and you have Blue Cross, I'll get $130. If I see you and you have Medicare, I'll get about $100. And if I see you and you have Medicaid in Missouri, I'm not sure here, I'll get about $30. So my office manager who wants me to pay her rent or pay her salary says, you don't see him so much. He says, well, that one's okay. This one, do you have any idea how bad her blood pressure is? You got to see her every week. Bring her in. And it's crazy, it sounds mean, but that's what we do this, right? Before we say you can come into our practice, we assess your financial impact on my practice, and that's just not the way a healthcare system is supposed to work. And no one else does that in their healthcare systems, and we gotta stop that. So he said this, and he said a single payer program like Canada's that covers all Americans is a far better solution for both the poor and the middle class. But until we get there, Medicaid is the only safety net for many low-income Americans. So that's sort of the connection in my mind. Back to the Affordable Care Act, I mean, the biggest flaw with the Affordable Care Act, in my mind, is that they hired the insurance industry to write it. So at the end of the day, they're embedded in it, and all of these problems that I won't read to you, but that we're familiar with, which would disappear under a single payer program, are still part and parcel to the American culture, and we need to fix this. So how do we fix this? We can fix this. We can fix this in our lifetimes. So Single payer is the phrase that we've been kicking around here, and you have to understand that it's not a single solution, that every country has its own little flavor of it. Every country that puts something in 3 to 5 years goes, oh, we didn't get that exactly right, let's change it. It's a reiterative process, you kind of keep evolving it. So, but the common threads are universal coverage for high quality care and no economic barriers to care. And there's many versions of this. So the spectrum would be over to the far side, a national health service. This is essentially how they do it in Great Britain, and it's the Veterans Administration. This is public funded, so tax dollars, and publicly delivered. So all the doctors and nurses pretty much work for the government. All the hospitals are owned by the government. This is not what I'm recommending. That seems, to me, and generally for our organization, that seems a bit extreme. That's really socialized medicine. That's not what we're talking about. The other extreme is this side of the room, where you have what I consider the Wild Wild West. Uniquely, Wild Wild Western Europe, it's us, where we have mixed funding. You have every flavor of funding you can imagine. And as a result of that, we all have to have that army of billing and accounts receivable people. We have gaps between care. So that's our current model. I submit to you that there's a place in between these two. There's a place in between these two. That's just a national health insurance. Don't socialize the medicine. I personally don't want to work for the government, just I don't want to. So go in between to this and put in just a national health insurance, which is like how Canada does it. It's like our Medicare program, public funding, taxes, private delivery. Keep the delivery model essentially the same, except for all the other things we need to improve about the delivery model. But the concept of single payer financing is unrelated directly almost to the idea of delivery. So preserve what we know is so good about our delivery model and fix the problems with it. So it turns out that there's a bill in Congress, H.R. 676, called the Improved and Expanded Medicare for All Act. Have you heard this, H.R. 676? Yes. I'd like you to repeat those 5 letters and numbers, H.R. 676.
H.R. 676.
That's the only reason I come here. I just love hearing a group say H.R. 676. So it's legislation in Congress. It's got, I think, 57 co-sponsors that would accomplish most of what we're saying. So there's a lot of ways to get to what we're talking about. This that I'm going to describe in a little more detail is, I think, clearly, as I'll show you, the most efficient way to do it, the most affordable way to do it, the least wasteful, the cheapest way to do it, and preserve practice models and preserve the quality of care, if not enhance it even. There are other ways to structure these things, but they're all a bit more expensive. So if you want to do something more expensive, I could go with you if it accomplishes what I really care about, which is not letting people die needlessly. So how do you do this? It's very simple, 2 simple things. The bill is 30 pages, double spaced. I recommend you read it. So we're just talking about fixing Medicare and giving it to everybody. Fixing Medicare. There's gaps in the benefit design, right? I can send a diabetic off to get their feet checked. I can get you laser coagulopathy. I can get you a stress test if you're diabetic. I can get you insulin if you have Part D. I can't actually get you an hour with a nutritionist. And you all know, you work with diabetic patients on Medicare, you all know there's with Medicare patients in general, there's a lot of problems with the benefit design. Easy to fix, put in dentistry, do the things we need to do to fix the benefit design. Get rid of the huge financial barriers that Medicare has emerged into it. So most seniors who can afford it today, as you know, purchase a wrap or supplement. So, those actually are just blanket disincentives to sometimes very important care. So get rid of that, don't mess with the delivery side though, and expand it, which means give it to everybody, including Congress, including the president, give it to everybody. And this is very important. If everybody is in this, then you don't need an army of people figuring out how to submit which claim to which place. You can actually have a global budget for places because there's only one payer. And so you can agree about this and have a long-term plan. It also means that everybody's in it, so Congress wouldn't be as inclined to marginalize it and undercut it and erode it, underfund it, because they're in it. If everybody's in the same program, it's way more sustainable. So the first question most folks have, and I'll bet somebody would have asked if I didn't end run it here, is what about the people who work in the insurance industry? And again, I know many people in the insurance industry. They're good, warm-hearted, smart folks in general. So they need a transition plan. You have to fund a support program for them. You need to get them, the bill talks about a 2-year guaranteed income for them for their salary up to $100,000 and job retraining. So understand though, these are not the best jobs in the world. As a matter of fact, there's about a 50% turnover of employees in the insurance industry over 2 years. 50% in 2 years, which means regardless of what we do about how we organize healthcare today, 2 years from now, roughly half of the people who work in the health insurance industry today will be working in some other industry 2 years from now. And then the rest, these are typically the folks that we would need to operate a good system. So you know, there's this issue, and it's thought out a bit in this bill that we're talking about. Insurance companies then have a niche, but their niche would not be selling any products that replicate what we have in the single payer model. So if we have this robust primary care, specialty care, drugs, dental, and all those things that are in Medicare that everybody has, and private insurance companies could not sell that. So they couldn't do that. They could sell other stuff, like if you wanted a policy that said, well, you're only going to get a private room no matter what you need, they could sell that. Around the world, single payer countries still have private insurance companies in a small way, typically. The ultra rich, you'll never include them in whatever system you set up, and that's fine, I guess. And so generally, roughly 5% or less of a country's healthcare expense winds up remaining in the private insurance industry. Less than 5%, essentially decimal dust. So you can make it work. You fund it through the progressive income tax, essentially, consolidate what we're currently spending, a modest increase in taxes in the way that I'm spelling out here, but get rid of the premiums and copays. At the end of the day, if you do that, I don't know the number for South Carolina because it's hard data to get, but in my state, it's probably very similar here, within a few $100, but I don't know the exact number. In Missouri, the average worker would have $7,500 more that they could spend on their kids' college education, on more stuff. It would be pumped right back into the economy, rather than going into some quiet little investment fund. $7,500 per person. They'd be spending a little more in taxes, but they'd be spending a lot less in premiums, copays, and deductibles. And at the end of the day, for the arithmetic, if you earn, raise your hand if you earn more than $500,000. Yeah, no, don't want to raise your hand? Okay. If you earn less than $500,000, like me, you would actually come out financially ahead with this model. So there is a small group that would pay more in taxes than they would say, but it's a small group. So Jerry Friedman, a professor of economics at Amherst, said, how does this all add up? If we did this, there would be new costs for the country. How much are they? So the Medicaid rate adjustment, you know, we'd have to start paying the same for you and for you and for you, and stop making physicians and hospitals assess the economics of the economic value that somebody brings, and just take care of patients like we want to do, you know. So we'd have to pay the same for everybody. That would cost something in the Medicaid group. The uninsured would, of course, cost something to give them access to health care, and they'd start doing stuff. They'd go to the dentist. They'd do these things. Now, some folks doing this analysis stop right here and say, we can't possibly afford this because look at all that red ink. And they stop right there. And, you know, those numbers that they would say would be true. But they really, that's not how you look at a balance sheet. You need to look at this side too. So the government at all levels would be administering one plan instead of, you know, the dozens of plans that they do today. Health insurance administration costs would plummet. We'd enable the government to negotiate the prices of drugs and devices. It's crazy that we don't do that today. And of course, the administrative costs for hospitals and physicians and stuff would plummet. At the end of the day, the overall cost of the program would be over $200 billion less, despite providing comprehensive health care to everybody here. This is what every other country has figured out. There are different analyses of this by different economists that come up with different assumptions and different numbers. They all come up with the green bar being bigger than the red bar. They all come up with the savings. And this is not where the argument is. Nobody really argues this part of it. So Canada's got some experience that we should look at on this. First of all, here's that relentless curve of the United States. Healthcare as a percent of GDP. You've seen this chart. It's pretty disturbing. We're like at 19% now. In 1971, President Richard Nixon signed the HMO Act, which was intended in part to lower the cost of healthcare. And it didn't really have a dramatic impact on our curve, but look at Canada's curve. It's a couple things here. First, way back over here, it turns out that Canada and the United States were on the exact same cost trajectory, cost trends, cost curves as each other. Did you know that? I didn't know that before I saw this chart. We were actually doing the same thing. And then we put in the HMO Act, and their costs went down. Can you explain this? Riddle me this? Actually, of course, it's a trick question because they also put in their single payer program. And note, that's when it was fully implemented. And notice it's not just that their curve went down from price negotiation, the shape of the curve, the slope of the curve decreased. And I don't have a hard correlate for you on this, but in my opinion, That's because they've gradually been accruing the value of long-term healthcare planning and seeing the improved health of their population translating into less expensive people to take care of. And to prove that point, I have this data at least. In 1975, the oldest year on here, they were living 1 year longer than we were. And I don't know why, but they're Canadians. They were living a year longer than we were. And then over the past 35 years, Canadians now live 2.5 years longer than we do. So that kind of supports this. You hear that physicians aren't happy in Canada. Physicians are leaving Canada in droves because they can't stand their single-payer system. And we all know physicians, well, I know physicians in Chicago and in St. Louis who moved out of Canada and came to the US, and I'll bet you got some here too, and I'll bet that they came here more than 10 years ago. Because more than 10 years ago, they were leaving the country in dozens or in a couple hundred, not in thousands, but they were. But that's history though. The last 10 years, Canadian physicians have been returning. And not only Canadian physicians have been returning, American physicians the last 10 years have been moving across the border into Canada. American physicians now have been moving into Canada because of how awful that single-payer system is. Here's one guy that did it. I think he's a family physician who was in Michigan. He moved to Ontario, and he was getting just really tired of those high accounts receivables and non-payables, and 30% not being paid by the insurance company. And he says in Canada, it doesn't happen, really. It doesn't happen. And we all know this. We all know that this is a big problem. The average physician has roughly $200,000 in accounts receivable. I encourage you not to look, but you probably have, on the average, $200,000 in accounts receivable, and most of that is aging quickly. Most of that is over a year old. So that's annoying, and it's just arithmetic, right? If your patients have a low-wage job and they have medical bills and they have the crummy underinsurance that we talk about typically, they're going to turn into your accounts receivable. That's the way it is. So at the end of the day, here's Canadian physician incomes in 2010 and 11. I'll just let you look at that for a second. These numbers compare rather favorably to those in the United States. Primary care is a little bit higher there. Specialty care, subspecialty care tends to be a little bit lower there, but they're pretty comparable numbers. And then if you look at these numbers, there's their own. If you are concerned about malpractice, and if a physician goes to a state legislator to talk about anything, and they find out you're a physician, they're going to think all you care about is tort reform, because it often is. Well, this is the secret to tort reform, is put in a single-payer program, because most people sue. The most common reason to sue, they've been injured or whatever, and they're worried about the future cost of their health care. That goes away. They don't have to worry about that. So they're not as likely to sue you to begin with. And when they do sue us, the judgment is largely, a big chunk of the judgment is for the future cost of care. Well, that goes away too. At the end of the day, those are the premiums. And so you put all this together, and most physicians in the United States actually say, yeah, I'd like a national health insurance. The average is 59% of American physicians in 2007. Survey hasn't been repeated yet. I think that it would go up, but I don't have any more recent data. And I say this because we don't like to talk to each other about it. Chances are half of you think this is a good idea. And we don't like to talk to each other about it, so we don't want to be branded, the single-payer person. So I'm saying it's not as risky to talk about it as you might think. Your friends probably agree with you, and this is what I call old-school social media. So the last thing I just wanted to show you is this little piece where they did a survey across the country, of course, and said, well, what do you think? Is Medicare worth what we pay? Is Medicare and Social Security worth what we pay? And it turns out most Americans say, yeah, duh, Medicare is worth what we pay for it, and Social Security. And then they went and asked the Tea Party, what do you think about Medicare and Social Security? And I bring this up because you might think that this is the most polarized question one of the most polarized questions you could ask. And believe me, I am not saying this to praise or criticize the Tea Party. I'm not in any way trying to really even discuss that, except to say that the Tea Party would probably agree that really high on their priority list is don't waste government funds. For crying out loud, you're taxing us, you're putting a gun to our head to pay these taxes. Don't waste what you're taking from me. That's really important to them. So raise your hand if you disagree and you think we should waste government. No, you don't. Okay. So they asked the Tea Party, what do you think? Is Medicare worth it? So I told you at the beginning that those volunteers all agree about helping each other and that we're not as polarized. This to me is sort of evidence that we tend to agree more than disagree, even the most seemingly polarized parts of our country. So I'm here because I have a fundamental belief that I believe you do too, that the country should be fair. I was brought up on Leave It to Beaver and Gunsmoke, but I was brought up on Leave It to Beaver. I think we should be fair, and it's just not fair that you live in one zip code and across the street in another zip code, you might live 15 years longer. You know, it's not fair that if you have a kid that's got a genetic disease that you didn't know you had the recessive trait for, that kid's medical care, no fault of yours or the kids, can make you have to sell your house like a patient of mine. That's not fair, and we should take that worry and fear of being one disease away from poverty off of our minds. Other countries think we're barbaric, that we make somebody who's sick go to the poorhouse. They don't understand this. They're puzzled by it. So I believe in fairness. I believe in fiscal prudence. I believe that this is the most prudent way to do it. It kills me that we're wasting the money that we are. If you can come up with another way to accomplish most of the same goals, but that costs more, we could talk about that, but I think this is the most prudent approach. And then lastly, I brought up and Leave It to Beaver. I believe in the United States. I think we should be the first in the world on everything. I do. And we're not in healthcare in some ways. We have, again, the best hospitals, doctors, nurses, schools, pharmacists. We're great at that. We don't have the best outcomes. We don't. And it kills me to be here showing you slides about how other countries do it better than we do. That just kills me. That just doesn't feel right. I want to live in the country where other countries are showing slides. People like me are there showing slides about those Americans. They figured it out. Look what they've done. I want to be in that country. I want when we can do that. We have all the parts. We know how to do it. Fix the few things we need to fix with Medicare. Give that to everybody at birth. Link it to Social Security. So they find you when you're 65. They get the Social Security. But give it to everybody. It's be really easy to administer compared to what we're currently embarking upon, and we can do this. So that's why I'm here. Last thing is, if you really kind of enjoyed this discussion, you found this kind of discussion useful, you should go to the website for Physicians for a National Health Program, South Carolina. You can join. You can at least find a wealth of information. You can go to our Facebook page and like us. So do stuff like that. And I think we saved a few minutes for questions. What else is on your mind? So she was first, the woman in the white shirt.
My
first question was just a small.
Use the mic because they're actually.
You have to push the little button until the red light comes on. Hold it. There we go.
So we'll give you your first question, but then we're going to get other questions, and if there's time, we'll come back for more.
I'll get them. Go ahead.
I'll repeat your question, so go ahead.
My first question was a small one on statistics, and then I'll ask you another question. She said 93%.
Okay, Martyrs.
Oh, here's the mic.
You showed a statistic that 93% of people had rapid access to elective surgery.
Within 4 months.
And so my small question was, are these insured people, uninsured people, everybody people?
Yeah, that's a great question. The question, in case you didn't hear it, is my statistic of 93% of people have access to elective surgery within 4 months. And the database that comes from, I don't think it actually articulates that. So I'm actually not sure if that's insured or global. I don't know the answer. I have looked for the answer, and I'm actually not sure. That's a good question. Let me get someone else. Oh, you had okay. We'll come back.
Scott. What's the plan like for people that own stocks in the insurance companies? Like, I'm assuming their stocks would be worthless in a single payer system. Do they get tough luck? Do they get reimbursed? Do they get U.S. bonds? I mean, what's the plan for that?
The economy would have an issue to deal with for the people that have stocks in the insurance industry. But there's a trade-off to that, which is that the non-insurance industry, which is actually the most of the country, is not really, we don't all work for the insurance companies just yet. The rest of the country, businesses in the rest of the country would actually become more globally competitive. So there would be a balance from that, but there would be a boost on this side. How that balances out, I don't think anyone has actually the arithmetic, but other countries have gone through this transition and their economies haven't collapsed over it. They've actually prospered and thrived and are exceeding us now. So it's sort of a soft answer to your question, but it's a good question.
Other comments? Surely. Yeah.
You were worried about private insurance companies. Well, in South Carolina, Blue Cross Blue Shield has roughly $2 billion in excess reserves. So, and they're a mutual insurance company. They've got it invested somewhere, you know, and they make most of their money managing information and processing Medicare claims.
Yeah, that's true. The insurance industry is primarily a data processing industry, really. And so what I would predict would happen would be that the insurance industry would diversify itself as it's currently doing, actually. You see them buying some of the delivery systems. You see them trying to invest in other parts or completely adjacent industries. So, you know, they'd find a way, I would imagine. They wouldn't be happy. But other than the insurance industry and the drug and device manufacturers, those are the two groups that don't really win under this model. The rest of the American economy wins. The rest of the American economy wins, and we just have to focus on helping the country.
Thank you. I think some of your ideas and some of the ideas are really good, especially having some sort of universal place to submit a claim and credentialing. I mean, that's just, I don't know about for y'all, but that's a nightmare to fill all that stuff out. In your system or this system, primary care would be a big emphasis? Is that what I heard? So how would nurse practitioners fit into this
Well, no matter
venue?
what,
Because all you talked about were physicians, so.
yeah, I'm sorry for that. No matter what we do with healthcare financing, we're facing an ever-expanding and looming and dire shortage of the ability to actually deliver the care to the 330 or so million Americans that we have, no matter what we do with the financing. So this model, of course, would do its best to address that. There's a budget, there's a global budget for operations, which is salaries, a global budget for capital, and a global budget for education. So education could be better organized. We could be training people more in accordance with what the public health needs are. And then the other piece, someone yesterday asked me, well, I want my bypass surgery here. I don't want to go, so, you know, and the answer really, for part of this long term, the reason Canada achieved what they've been achieving is let's not make people need these things. If we improve the public health, the demand for these high-end things could be prevented or mitigated or delayed, and those are really good things. We today have decided that if you have kidney failure, you get Medicare. So if you get kidney failure, if your kidneys blow out, I'm going to pay the $50,000 a year for dialysis or whatever the current cost is. Maybe it's more, I don't know what the current cost is, it's probably more, I don't know. On the other hand, 2 years earlier, it would be a much wiser and more prudent investment to buy the hydrochlorothiazide for you and prevent you, or at least delay your need for that. And if we get on top of this, we should be able to impact that. And yes, absolutely, we have to look at extended models. We have to, you know, really take full advantage of all of our professionals, not just the physicians, as I was saying. You're absolutely right.
Yeah, I think the bottom line is that you're a nurse practitioner, right? Yeah. That we could do what we wanted depending on how our workforce is when we implement this.
That's
and
right.
it could be fluid depending on people that are coming forth to go to medical school or become PAs or whatever.
Well said.
Brian?
In this model, how would a single payer system look at utilization review? You know, if you're getting so many dollars per procedure, people are going to crank up the number of procedures, right?
Yep.
So how do you do UR?
Yeah, well, the first thing, of course, is to remove the perverse incentives that we have today. So today, you know, it's entirely, you know, if you do more, you get paid more. So this system formally puts in regional budgets. And then those regional budgets get distributed in the way that that region thinks makes the most sense, in a way that's reviewed by citizens and physicians and a group of non-biased, non-conflicted folks. And so the system that would manage that would be one that would have to be emerged. But it would have to deal with that. You're absolutely right. A good example would be that today, if a pharmacy benefit company says, I don't want you to use this drug, I want you to use this other drug, it's done in a very arcane, painful way where they just say no. Instead, you should just design the system so that the right thing to do, the affordable thing to do, is the easy thing to do, and it's just you have to actually explain why you're not doing the right and affordable thing to do. So you can design the system so that we still have autonomy, but we can practice within guidelines.
Yeah, I think I mean, the tensions are in Canada the same as here about, how many cardiac caths is too many, and they have to struggle with the same questions. This doesn't eliminate the sort of the internal struggle about allocating among procedures.
No, it doesn't. And part of the issue too, of course, is that we've decided to train two out of 3 physicians in the United States today are subspecialists, and in the rest of the world, it's 1 out of 3 that are subspecialists. So we have a mix of physicians that are different from what anybody else in the world thinks makes sense. So those folks need business, and we could probably keep people pretty busy if we balance this properly.
So how do you keep politics out of this? You say have regional budgets. I can just see those strong congressmen from New York getting a lot of money, and they have great hospitals where the South suffers. I think the VA had the same problem some years ago. They were trying to close beds in the Northeast because veterans were going to the South to retire, and they had empty hospital beds up there. And no, that's gonna cut. You're going to cut dollars to my district. Don't do that.
So a couple things. First, today we have for-profit, Wall Street traded businesses making these decisions, and I submit to you that that's inherently worse than having elected officials manage it. And I submit to you that most Americans want this to work right, and that since we would all be in the same pool, everybody in, nobody out, that mantra, so we would all be in this, we would be able to make it be more effective than, Medicare, this isn't magical science that we're making up this theoretical thing on a chalkboard. We have today, literally today, 49 years of experience with Medicare. And Medicare's costs are growing more slowly, age adjusted, for the rest of the country. Medicare today has higher satisfaction rates among seniors than most, if not any, other health plan. Medicare today has great outcomes compared to most other systems. So we know how to do this. It's not a theoretical thing, and it doesn't solve every problem in the world by any means, but we've got a pretty good history. Now, today's the start of the 50th year with that.
There's a number of hospital administrators here. Could you explain a little bit of how global budgeting works to fund hospitals, in addition to everybody having access, so we wouldn't be pulling in people in the ER with no insurance, but aside from that, how that works, how hospitals get paid under the Canadian system, for example?
So today, hospitals, as physicians in practice and medical groups have to do, you have to look and manage closely your payer mix. You have to have more of the better paid, not so many of the lesser paid. You have to decide how much Medicaid you can absorb or how much uninsured you can absorb. Today, that's a big game. And if you play that game right, you can prosper. And if you decide that you're big-hearted and you're going to be doing a lot more of the charity care, you'd better have a pretty good strategy for funding that, because it's, as you know, with dish cuts, that's getting worse, not better. So today we have that. Under the more sane system, in my mind, what you do is take all of those revenue streams and create a global budget for the region, which then gets distributed to the hospitals in a fair way. And then that hospital has 3 distinct unfungible budgets. One for operations, nurses' salaries, physician salaries, operations, all of that, nurse practitioner salaries, all of the stuff, all of the operations. A second discrete non-fungible budget for capital, so you can't understaff the nursing side in order to put in the new imaging device, and then a third budget for education. So that's sort of a high-level summary of that. I don't know if you had more you wanted to say about that?
Yeah, no, I think it's a really important issue, because I remember I heard a speech like 25 years ago for somebody who designed it. It was either Ontario or the Quebec Health Plan, who was giving a speech and said, it was in Boston, said, down the street here, Mass General Hospital has 800 people employed by billing. Toronto General, another 800-bed hospital, has 2 to bill foreigners who come here. That whole itemized 100-page bill goes out the window. The hospital has to figure out a way that its global budget will work for the next year, and I'm sure there are intense negotiations that lead to your annual budget, but at least the people internally are deciding where to spend that money and not billing for tissues and Tylenol.
Yeah, exactly.
More questions? Yep.
Some of us worry
you go.
about a Congress.
Wait.
Some of us worry about a Congress that's easily purchased when it's not extorting. And we are concerned with the centralization of power. With your suggestions, how can we make this regionalized and get rid of the centralization of power in Washington? when the services are for sick people here to be delivered by health workers here?
Yeah, so the question is, can we trust the government to do this? And it's a central, pardon me? So, and you're taking the example of the problems that are pretty apparent now at the VA. And what I would say is that's an example of having a fragmented system. The VA is over here. We all like to wave the flag and say we support the vets, but when they try to get their budget adjusted, the VA's budget has increased appropriately for inflation, but with nothing to adjust for the demand upon it. And so they've been getting more and more. Pardon me?
They have an enormous increase in employees in the central office for no good reason.
Yeah, so the issue, of course, is that we need to be able to get on top of this. I doubt that we can accomplish what I've been proposing with our current strategy for campaign finance. So our current strategy for campaign finance undermines our ability to do a lot of things. And part of why I like talking about this is I think this topic leads inexorably to the need to correct the campaign finance strategy that the country has. So, but if we do that, then we can fix things.
Okay, I guess it's a little after 5. Oh,
I was gonna,
last question.
I was going to ask about the VA and the TRICARE system, which already exists. Are these good examples, do you think? Or do we find problems in these existing systems that, if expanded to 330 million people, would be too much?
Well, as I said at the beginning, I don't personally support having a program that's actually socialized medicine, of having all doctors and hospitals and nurse practitioners employed by the government. I don't think that's a model that's palatable to the American culture. So that's really not what I'm proposing. The VA has gotten a lot of press because of how their budget's inadequate and the waiting times. And what's not quite.
What about TRICARE for active duty military and families of active duty military and retirees?
Right. I can't actually say that I'm expert on the TRICARE topic. I don't.
I can speak just a little bit. Hi, I'm David Ball. I'm also with the Physicians for National Health Program. I was a VA scholar. I've been a VA nurse. I'm a combat veteran, so I'm a patient at the VA. And so I have a little bit of experience with TRICARE and the VA system. And I just give you an impression. I don't have statistics with me, but I will tell you that that patients at the VA get better care than people that are not VA patients. Okay, and that's socialized medicine. So, in and of itself, I'm not necessarily a proponent for or against socialized medicine, but I will tell you that the metrics of the people that are VA patients are better than they are for this hospital and for outside the VA. I think that a lot of their problems have to do with their funding. You get a lot of patients. You're told you're mandated to take care of people. If you get performance bonuses based on wait times, well, we'll just kind of move some numbers around and things like that. There's obviously some things that have been wrong. But does the fact that there are problems at the VA mean that the VA is fundamentally flawed, or that it's not a good system, or that the government doesn't do a good job? I don't believe that that's true. I will say that my issue with TRICARE, and TRICARE is a very affordable way of providing health care, and they do a good job, is that it is not a very portable system. And particularly for active duty people that move around every 3 years, that's one of the fundamental things that I would think that any system like that should be. So,
I think a lot of the anecdotes I hear from our residents and everybody else who works at the VA, there's a lot of bureaucracy at the VA that doesn't make sense, like a lot of the other bureaucracy in the non-VA system. And people have, any system is going to have to look carefully at the bureaucracy that it builds. It's not just snap a finger, single payer will solve the problems, but that managed appropriately, it offers, I certainly agree, the best opportunity to make an impact. So, anyway.
Just once again, thank you everyone for being here. Just one little note. If Canada, when they implemented single payer, they went one province. And it was the experience of that one province that convinced the rest of the country to go to single payer. So there are some folks in our country who advocate let a state or a couple of states adopt single payer. And in fact, the state of Vermont is on track to implement a single payer model starting in 2017. So if you want to do a little more reading and if you join us, go to our website, but also look at the experience that has gone on politically in the state of Vermont for them to have put this single payer system on track for 2017. Once again, let's hear a round of applause for and we do have a couple of handouts if you're interested in a little comparison sheet about the Affordable Care Act and single payer, and want to pick up a brochure about the Physicians for National Health program. We've got them up front here on the stage, so we're here to answer questions as well. Thank you again.